Hello, everyone. Welcome to my webinar. It's October 20th, 2015. This is Randy Wong. I'm a retina specialist in Fairfax, Virginia, and we are going to talk about the treatment of floaters, frequently asked questions. However, tonight we also have two very special guests. So what I'd like to do tonight is go over kind of the really more frequent questions before surgery, which are usually my questions, and then the questions after surgery, which are usually your questions. And then we will have John and Mark introduce themselves, tell a little bit about themselves and a little about their story, and then open up the floor for questions from the attendees. And if everyone thinks that's okay, I'd like to keep this about an hour. I'm just curious. I just want to double check that people can hear me. For any of the attendees, I can talk to the panelists, but I can't talk to the attendees. If you could just type in the chat box that you can hear me, and we'll get started in just a minute. Thanks, John. Thank you, Chrissy. All right, now I'm going to try something really daring. I'm going to turn my web camera on. And I don't know where it's going to show up. Can you guys see me?
I see you, and you're on. I can see you you're at that 9 o'clock position on the screen.
Huh.
I can't see you.
All right. Well, I'm going to turn it off and I'll add it when I record this. You cannot see me any longer? John, can you see me?
No, I can't see you anymore.
Okay. All right. So thanks for coming. We're going to get started. I'm going to have a very, very, very short slide series. This is the treatment of floaters, frequently asked questions. Again, I'm Randy Wong. You can check out my website at vitrectomyforfloaters.com. Let's get started. So as I just said, I'm a retina specialist on Fairfax, Virginia, and Fairfax is just about 20 minutes outside of Washington, D.C. My website specifically for patients with floaters is www.vitrectomyforfloaters.com. What I'd like to do tonight is talk about the process of getting an appointment, getting a vitrectomy, and what we do afterwards. We'll talk about frequently asked questions before surgery, and then talk about frequently asked questions after surgery. And because I was able to get two special guests tonight, I'd like to introduce them and have them tell their story, and then open up the floor to specific questions you might have for the guests or you may have for me. The process is pretty simple. At some point, you've followed me or you've seen our material or you've come to our website and you want to schedule an initial consultation. And the easiest way to do that is to just go through Chrissy. Chrissy has been handling all my digital appointments for the last several years. Here's her email. It's rwongcm13@gmail.com. If and when you're ready, and there's no hurry, to come see me, just reach out to her. She'll take care of all the logistics. She'll help you with finding out whether or not your insurance is going to work, and then helping you figure out what weeks may be great for an appointment, et cetera, et cetera. Surgery is done as an outpatient. It's done at this, as same-day surgery. Typically, it's done on a Friday. You will often come to see me Thursday or Wednesday before that Friday. If we decide that we should proceed with surgery, we'll have surgery on that following Friday morning. It's done as an outpatient. You go home within a couple hours, and then I will see you on Saturday, take off the patch and start the drops. Something's come up that's new. We need to make sure that you have a ride, not a taxi, to take you home from the surgical center. It's beyond my control, and I apologize. You will go home with a patch. You don't need to do anything that day, but the hospital is now insisting that you have someone that is known to you to help you get home. Basically, the next day we'll take off the patch and start the drops. So when I see you, there's all kinds of questions when we first meet. A lot of you have done your research. A lot of you are listening, to this webinar to learn more about the process of vitrectomy to remove your floaters. On the first day or the first encounter, I actually have the most questions. One of the biggest, most important questions that I have is, do the floaters move or are they fixed? And it's very important because they should swish back and forth or up and down with eye movement. They should not be fixed, because if they're actually in the vitreous is kind of fluid, or it's been described as a gel, so that the floaters need to swish back and forth or move with eye movement. There needs to be some lag. And if so, then I know whatever you're seeing has got to be in the vitreous, and therefore the vitrectomy is going to help you. When I see you in the office, I'm very interested to see whether or not you've got any evidence of other eye disease. Remember, floaters can come from a PVD. That's the most common cause. But there can also be floaters from blood or inflammation. So floaters from blood might be from a disease like diabetic retinopathy or something else that's wrong with the retina. So I got to make sure that whatever you're seeing is not from a vascular problem like diabetes that's affecting the retina. On fewer occasions, a small percentage of people have floaters from inflammation or uveitis. And most people know they have a history of this, but just in case you don't, I need to make sure that your eye looks to me to be very healthy. Then I need to establish whether or not there's a PVD, because if there's a PVD and we decide to proceed with surgery, a PVD is the easiest scenario for me to perform surgery to remove your floaters. And the reason is I don't have to create a PVD. And we have one guest tonight who had a PVD induced, and we have a second guest tonight who already came to me with a PVD. And there'll be some subtle nuances as to what the differences are. The next thing I'm curious, or the next question I have is there a cataract? And the whole question of cataracts on the internet are very kind of disturbing because I think they're overplayed. In my experience and my statement about cataracts and FOV are the following. Cataracts can happen, but they're unlikely. I'm not so sure why there's the sentiment on the internet that everybody immediately following vitrectomy is going to get a cataract. In my experience, in my observations, that's just not true. So my party line for cataracts is, yes, it can happen. Yes, they can be accelerated by vitrectomy, but it's unlikely. So I'm very curious during our initial consultation to establish whether or not you've got a cataract, so we can talk a little bit about that. Another common question that I get as a doctor is, can I see the floaters? And for those of you that have been through this or read my website, I actually don't care to look for your floaters. And the reason is that your own vitreous is supposed to be 100% clear to you, whereas I, as your doctor, should be able to see your entire vitreous. So it doesn't really matter, or it makes it impossible for me to see exactly what you're seeing. The most important thing for me is that you establish or you confirm that whatever you're seeing moves back and forth with eye movement, because I know then it can only be in the vitreous. Excuse me. And the last thing that we commonly need to talk about is whether or not we want to put stitches, use stitches, even though this is 25 gauge. And I think you've been following me carefully, probably in the last couple of years. I've decided, especially for my young patients, that it's probably easiest if we put stitches in at the end of the operation, even though this is 25 gauge, because this just takes away some of the potential problems. Although temporary and although benign, it just reduces the problem list after surgery. Now, questions after surgery usually come from the patient. How come my vision so poor? What about pain, activity, warning signs? How do I take my drops? What about these stitches? And then follow-up. So let's go down the list. So why is vision poor? As John and Mark will attest, the day after surgery, the patch comes off, and I do not waste time trying to get you to read the smallest little line on the eye chart. And the reason is there are so many reasons that your vision should be poor the day following surgery. I expect your vision to be poor. Number one, you've had a patch. Number two, you just had an operation. Number three, you may have had a PVD induced. So I only need to establish that you're able to see light. Sometimes people have double vision, and that's from the anesthesia or the local block that we give. But all of that is temporary, and all that usually turns around in a quick 24 to 48 hours. Now, having said that, when you take the patch off, sometimes you even still see floaters. But it is the usual case that when I take the patch off, that's the worst your vision is going to be, and from there on, there's continued improvement or clear sailing. There is almost never any pain. I don't think I've ever had to prescribe any medicines for pain control after a vitrectomy. Usually, whatever you would take for a headache, Tylenol, Advil, aspirin, is sufficient if you were to have some discomfort. But I don't expect you to have any discomfort. You may resume full activity within 24 to 48 hours. I insist, actually, that you don't reduce your activity. There are two times when I want you to call me or let me know that there's a problem. And that's if you develop pain that does not go away with your normal headache medicine, or if you feel that your vision is actually getting worse. Now, there's a difference between your vision getting worse and not improving as fast as you'd like. However, if your vision were to go backwards, I really want to know about that. And there's two reasons for this. Number one, perhaps that these could be early signs of early infection, or number two, a complication of surgery such as retinal detachment. As far as drops are concerned, I make it really easy. There's only two drops. There's a white top and a tan top. The white top's an antibiotic. The white top's a steroid. The tan top is a antibiotic. You use it 4 times a day, 1 drop each, until you follow up with either me or your doctor at home. Stitches generally don't hurt. You can usually feel that there's a foreign body sensation, or maybe something's in your eye, but most people can't actually feel them. They'll last about 4 to 6 weeks, and then they'll fall out naturally because they'll dissolve. But for the first day or two, until they get soft by absorbing your tears, you might be able to feel them. As far as follow-up is concerned, I really want you to come to the office to see me already knowing that you've got your own doctor appointment or an appointment with your own doctor in 7 to 10 days, because that's when I'd normally see you if you were to stick around to see me. Now, if you want to see me, you're absolutely welcome to. And I certainly have patients that either come back or stay so I can see them in follow-up. It doesn't mean that that's their last follow-up, but generally the first office appointment after surgery, that's the most critical period. What I'd like to do at this time is I'd like to welcome John and Mark. They are both patients of mine. They have both had an FOV. John came to me already having had a PVD, and Mark needed to have an induced PVD. John, I'm going to ask you to go first to tell your story, and then Mark, and then we'll open up the webinar to questions. So John, tell us a little about who you are and what you've been through and whatever you want to share.
Okay, thank you very much. My history of floaters goes back almost 40 years. When I was 12, I first noticed them. Have talked with optometrists and ophthalmologists over the years, and the general consensus was you just live with them. They talked about the only treatment was vitrectomy, and any doctor I talked with, when they talked about vitrectomy, it was, you don't want to do that, it's very scary. I even tried about 10 years ago, there was a doctor in Falls Church who was doing YAG laser treatment for floaters. I tried that, it broke them up, it dispersed them a little bit for a day or so, but then they came back. The floaters have never been that terrible for me. I would have squiggles, lines that would float through in my vision, and it never, I was able to do all the normal things that I need to do during the day. That changed about 2013 because I've seen Dr. Wong. This is my second procedure. The first one was on my right eye in 2013.
You can call me Randy.
Thank you, Randy. In 2013, my vision got progressively worse. We didn't diagnose a vitreal detachment at that point, but I had one floater that kept getting in my right eye, right in the middle of my vision, and it made it very difficult for distance, for driving, etc. And I've been doing research about every 6 months. I would go on the web and try and find different treatments for floaters. That was how I found the laser, and I found Dr. Randy's website, and just with the way he presented things, with the information, plus his background, his training, I knew this was the person that I needed to talk to, because I had considered even cold calling some of the ophthalmologists at some of the bigger eye centers in our area to see what we could do about this and vitrectomy. So called Dr. Wong, went in, had the visit, no problem. Within a couple weeks, I had my first procedure. It didn't take very long. I was in the morning. I think the whole procedure, the vitrectomy, lasted about 10 minutes. And I was waking up. They brought me back into recovery. And from the time that the procedure started to when I walked out the door, it was about an hour. There was no pain involved with it, no discomfort at all. Followed up the next morning, got the patch off. On my right eye, my vision was blurry, had a little red tinge to it, but that cleared within a day or so, plus my eye was still dilated, got better. So that was it. About 5 months later, 6 months later, it was April timeframe, my vision had started to decrease in my right eye. I wound up developing a cataract. There was no problem with it. It was just trying to get my glasses and get my vision adjusted. Went into
John, I'm sorry, which eye did we operate on first?
The right eye was my first one.
Okay.
The one that you just did was my left eye.
Okay.
And so I went into one of the other ophthalmologists in his office, and who specializes in cataracts. They did a cataract replacement. Similar thing. One day, outpatient, no pain, and I'm very pleased with it because I've worn glasses all my life. They put a corrective cataract in, and my vision on my right eye is perfect. 2015, no floaters. I'm very pleased with it. So if I come up with a cataract in my left eye, I have no concerns about it. I'm very happy.
Let me just interject for all that you're listening, is that John is older than most of us. Most of the patients, he had a PVD, and because he's at a PVD and because he's a little bit older and he had established or early cataracts, that's usually the norm. Versus we'll hear from Mark where it's a little bit different. So I know everyone's listening right there going, you just said this doesn't cause cataracts. But what I'm stipulating is that because there's a pre-existing cataract, months later, it can happen. It's not the end of the world, as John will tell you. I'm sorry to interrupt, John.
No, it's fine, and I definitely don't want to discourage anybody. You were mentioning concern about cataracts. My whole point is, if you do happen to get one, it's not end of the world. The treatment is easy, very similar, and I'm very pleased with it. Left eye was worse situation a couple months ago in April. My vision got markedly worse. Instead of the little squiggles, it was like smudged eyeglasses all the time. Wanted to see Dr. Wong again, and that's when he found out that I had a PVD. And same thing, we scheduled for the procedure. I just had my 7-day checkup. Very similar, went in, they put me to sleep, light anesthesia, but it didn't last very long. Got up, and from the time that the procedure started to the time that I was heading out to the car with my driver, it was about an hour. No pain at any time. I still have no pain. The vision is great, and it's very pleased. And that's it.
Thank you, John. I really, really appreciate it. Now I'd like Mark to tell his story, and then we'll open this up to questions.
Okay, thanks, Dr. Wong. My story is very similar to John's. I had floaters for about 10 years. None of them really bothered me. I was able to go around with my daily life, no problem.
Mark, how old are you?
I am 38, just turned 38.
I thought you were 24.
So it's no, that's about when I first saw the floaters, but thanks, I appreciate that. No, I saw the floaters and was just like John, was told to live with them. It's bugs on a windshield, I think is what the first eye doctor told me. And I did that for the better part of 10 years, maybe 15 years. And then for the last year or so, they got really, really bad, started blurring vision, messing with lights, making coaching and playing sports nearly, not impossible, but very, very difficult and very unenjoyable. So I, like John, went on the internet, started researching, and then found Dr. Wong, watched some of his old webinars, signed up for one that he had coming up like a week or two later, and got as much education as I could, and decided at that point that it was time to fly out and see Dr. Wong. And
Mark, you have to call me Randy also.
Okay, I will. I'll try. So I went out, I saw Randy, and he basically just said in a nice calm voice, I can help you. And we went forward from there, just like John. Surgery was running smooth. His office, his staff, his OR staff, everybody is amazing, very friendly, make you feel comfortable about something that seems very, very scary, especially considering how many eye doctors tell you not to do it, live with it. Everybody has them. And I'm now, I think, 12 weeks out from the right eye, and it's unbelievable. The vision is perfect. I couldn't be happier with the results of my right eye. And yeah, the staff, everybody helps you finding hotels, places to eat, even very friendly.
Yeah.
Which I could give recommendations on some places as well. So.
Well, that's terrific. Thank you both again for attending and participating and telling your story. I'm going to open up the webinar to questions. I already have the first question from JB. How long should I wait before getting cataract surgery after FOV? What if my poor vision from the FOV and from is accelerated? Wait, what if my poor vision from the FOV and from accelerated cataract is debilitating? Well, if this were to happen, there's no reason why you can't get cataract surgery quickly if you need it. Having a vitrectomy doesn't obviate the need or the ability for you to have cataract surgery. Any other questions from anybody? Just type it in the questions area. MK is going to ask, for a PV-induced vitrectomy, how often is there a retinal detachment? MK, I think I got an email from you this morning. I would say we get a retinal detachment probably 1 to 2% of the time. And the retinal detachment, if it were to happen, does not happen immediately. It usually happens within the first couple of weeks after surgery, however. The idea of inducing a PVD is to get rid of most of the vitreous. Unfortunately, it basically requires you to tug on the vitreous, which is attached to the retina, so there's a possibility that you tear that. I think that our techniques over the last couple of years have improved, so we've been able to reduce that. But full disclosure, I think still about 1 to 2% of the time when you're inducing a PVD, you could create a tear. And of those, not all turn into retinal detachments. But I think you need to be generous in thinking, and it's probably somewhere around 2, maybe 3% at most. You're welcome, JB. As we wait for more questions, I'm going to ask, John, I don't recall that I used stitches in you, so that, how many days was it after surgery that, you felt your eyes felt normal?
You're correct. On both procedures, you did not use stitches. And my eyes, except for the dilation, the blurry vision from that, my eyes felt normal the next day. There was really no irritation, nothing that bothered me. So within a day or so.
And how long would you guess, just estimate, when did your vision return back to normal?
See, I had it on Friday. I think my vision, it was sometime Sunday. Okay. So about 2 days afterwards.
All right. Mark, what would you say?
Same. I had the stitches, so I had felt that sensation you were referring to.
Yeah.
Where just something was there. It wasn't bothersome. You just kind of felt that, and that went away. Probably 4 or 5 days, maybe a week.
Great. Terrific.
And the vision. I think by the time I was flying home, I was feeling very confident about the vision. So almost a couple hours after you took the patch off.
And that's a good point. Most patients are able to leave, the following day. And as I said earlier, you can expect to return to full activity, physical activity, within 24, 48 hours. Taking a train or flying home doesn't really matter, or driving. There seems to be some question as to whether or not you can fly, but there's no reason for us to put gas in the eye after the FOV, and that would be the only reason why you couldn't fly. So most patients come in early in the week. We operate on Friday, and they're out of town and going back home by Saturday. So it's really pretty remarkable. JB asks, okay, thank you. How long should I give myself to recover from FOV and cataract surgery before going back to schoolwork? Well, I think it really depends on how comfortable you are going back and working. As far as I'm concerned, as I just said, within a day or two, you should be able to resume, pretty much all your activities, including studies and schoolwork.
Randy, I can, if you don't mind.
Yeah.
For myself, I was back to work on Monday, both days. So after my FOV, and then for the right eye after my cataract, there was no restrictions, no problems. So I had them done at the end of the week, and I was back at work without any difficulties.
That's terrific. Mark, I think you went back pretty quickly.
Well.
Yeah. And Mark, why don't you share with everybody what you do for a living?
I'm a PE teacher, so I actually went back with a little bit of hesitancy, worrying about getting hit. But the moment I went back, I just kept hearing your voice saying, "Hey, no restraints, just do what you do." And it took me maybe about an hour, and I was doing what I do and never turned back. So that was about it. Got back right away.
Trying to advance. There we go. JB also wants to know for John, how long did you wait after FOV before getting cataract surgery?
The vision didn't change on me, so I had it in October, November, I think was the first time, and I noticed over several months I would go in, I would get my glasses adjusted, get my prescription adjusted, because I've worn glasses most of my life. So my vision changed, and we noticed, my doctor and I, over time, my prescription's normally 5.25, 5.25, and I was up to 6.5, and that's when he realized, with all the visits and with the changing, he took a closer look, and he's like, "I think you may have a cataract." And I didn't notice it. I always thought of cataracts as a white out and hard to see, etc. That wasn't what I had. So went in and saw the ophthalmologist, and they did a couple of tests and confirmed the cataract. So it was probably about 5 or 6 months of slow progression. It wasn't debilitating. It was just, I noticed it and it was aggravating, especially for distance vision. It wasn't quite as clear as I would have liked it, and that's when we picked up the cataract and went ahead and scheduled. It wasn't, I have to get in, I have to get this done, I can't see anything. It wasn't that bad.
Oh, terrific. Mark, anything you want to add? Well, you didn't really have a cataract, so.
No, I didn't have any experience with the cataracts.
I just turned my webcam on just to do something new and interesting. Haven't done that before. I can't see me on my own screen, so I have my new glasses and you can see my headphones. But anyway, MK, new floaters. Is this a common issue? New floaters, do you mean after surgery or just new floaters in general? If you have new floaters in general, or anytime you have new floaters, you always have to worry about a retinal tear. Recommendations are to get examined within 24 to 72 hours after the new floaters, because you can't distinguish between just floaters from a PVD or floaters from your vitreous or floaters from blood versus a retinal tear, which could lead to a retinal detachment. So the recommendation for new floaters is to get examined to make sure you don't have a tear in your retina. Once you establish that, then you can kind of pick and choose what you want to do about the floaters. Floaters after the operation are common. When we take the patch off the first day, it's very common to have some floaters, but you'll notice that the way they move or the size or shape are all different, because these floaters are either from the inflammation from surgery. There could be a little bit of blood. There could be kenalog that's floating around in there, etc., etc. So if they're new floaters and you haven't, basically the bottom line is, for new floaters, get examined. Floaters after the operation, probably don't worry, especially because generally you just saw me. We just always are worried about the integrity of your retina. Another JB, for your FOV patients who have already had cataract surgery, do you routinely open the posterior capsule during the FOV, even if the capsule is clear, to obviate future laser posterior capsule surgery? Never had this question before. Very insightful. What JB is alluding to or asking is that cataract is just like an M&M. When cataract surgery is performed, on the front side of the candy coating, a hole is made. And then we use an instrument to suck out the chocolate, which is actually the cataract. The candy coating that's left is usually clear as saran wrap, and we use that as a sac to place the clear plastic implant. Now that candy coating, which is as clear as saran wrap at the end of the operation, almost always gets cloudy after surgery. Probably the chance of it getting cloudy is about 100% by 10 years. And this can further blur this can cause recurrent blurring of vision. And a common procedure to clear this up is to use a laser in the office to poke a hole in this hazy candy coating. So that's known as a YAG capsulotomy. And what JB's asking me is, since I'm operating inside the eye, do I routinely make a hole in the candy coating so you don't need laser in the future? And the answer is no, I do not. I will tell you, though, if there is clouding that I notice preoperatively or clouding during the operation, I will do it. But I don't routinely do it regardless of the clarity. So if it's cloudy, I will consider doing it. We've talked about it. Certainly I'll do it. That's a really good question. Another JB. Wow, there's a lot of them tonight. Can you establish if a full PVD has taken place at the consultation, or do you determine this during surgery? And at what age does a PVD typically happen? I don't believe there is anything called a partial PVD. I read lots of times that doctors tell patients there's a partial PVD. A PVD probably occurs over several days to a couple weeks, but the end result is a complete PVD, meaning the posterior vitreous is completely separated from the retina, probably out to what we call the equator, or halfway towards the front. I can usually see this during the preoperative evaluation, but it's kind of a moot point because it's more important for me just to establish if there is some PVD at the consultation, so I know I don't have to induce one, and we have to talk about inducing a PVD. JD, what is the best answer to give to friends, relatives who ask me why I need to travel so far to have my eyes fixed instead of getting it done here in Atlanta? Saying that most doctors won't do it because they think it is unnecessary leads to more questions that I'm unable to answer, such as, why won't most doctors do it? Is there a simple answer to this? Sorry if this question is worded strangely. I think you kind of hit the nail on the head. Mark?
Yeah.
Try this one.
I feel your pain. It's, for whatever reason, I think Dr. or Randy said it best, that there's a lot of misinformation about FOV surgery. And for whatever reason, they're looking at an otherwise healthy eye, and they're trying to normalize it as much as they can for you, when they're not actually taking into account that what you're seeing is truly bothersome to your daily life. And when you have a doctor as compassionate as Randy, it's too bad more doctors out in the world aren't helping out the way Randy is. And I can't really explain why they do that, but I understand what you're asking. And it is hard, especially when you start to talk to family members who don't get it. But for those of us that have gone through it, and there are people that get it, is what I'm saying. And Dr. Wong is one of those people that gets it. And I think if that made any sense, that's probably the best answer I can give you.
John, anything to add?
Yes, actually. My thought on it, because there's lots of doctors in the area when I was researching this, and I might be able to find another ophthalmologist that would be willing to do this. But the reason I was looking to Randy, why I liked going to him is, and especially having been there now twice, is his experience. That counts a lot to me in terms of my comfort level. If you see another ophthalmologist, don't know. I'm just going to guess, but they may do a vitrectomy, occasionally. They don't do it consistently. The 2 times I've done this, we've had 4 or 5 patients at a time, for the follow-up for the next day. Dr. Wong Randy does this consistently, frequently. His experience, it counts a lot to me. So that would be why I would travel, to go to somebody who knows what they're doing and who does this frequently, and who knows what to look for follow-up and for questions. So that's my thoughts on it. Experience.
What I want to add is that I couldn't do this if I hadn't done this for a long time. It takes a little bit for me to put myself online and say, this is what I do and this is what I'm worried about. But overall, this is no more scary or difficult than cataract surgery. Had I been in the beginning, Had I been in the beginning of my career, I'm not so sure I would have the confidence to do this. But after 24 years and doing tons of vitrectomies, I know what the real risks are, and I know what the issues are. And as everyone, probably all of you know, is that vitrectomy, or FOV, is certainly safer than cataract surgery in terms of endophthalmitis. The chance of endophthalmitis in cataract surgery is 1 chance in 2,000. That's not my statistics. Those are global. I don't even do cataract surgery. Chance of getting endophthalmitis, that same blinding infection in vitrectomy, at most is 1 in 10,000. Again, not my statistics. So right there, much safer in terms of infection. I think with the chance of getting a tear that could lead to retinal detachment for cataract surgery is very similar to having vitrectomy. Vitrectomy with induced PVD, maybe you're increasing your risk a little bit. We just don't know. It just doesn't happen that often. And, if you read, most of the stuff I have online, I'm your advocate. I'm here because I understand that just because you don't have cataracts, you're still having problems with your vision, and there's a cure. And as far as I'm concerned, if you understand what the risks are and accept them, then we as adults can move forward and come to a solution. Now, to get back to your real question, JD, is why do most people not say this? Is vitrectomy was invented and widely available starting in the 1980s, give or take a couple years. Up until then, patients with retinal detachment due to diabetes, and that's the most common cause, had no alternative until vitrectomy was invented. And so now patients with really bad, likely to go blind disease now could undergo a vitrectomy. And unfortunately, for the first probably generation, these patients who had no hope tried vitrectomy, and there weren't enough people that knew how to use this new technology, and they went blind. This was only in the 1980s. There are plenty of doctors that are still in practice that remember the 1980s, and their association is vitrectomy, blindness. And I don't blame them for this. It's just that things have changed so much since the 1980s. I mean, Back to the Future, just celebrating their 30th anniversary. In that time period, the technology has changed so much that the complications have really approached complications of cataract surgery, the most common surgery in the world. But that fact escapes most eye doctors, whether it's general ophthalmologists or optometrists. Any non-retina specialist isn't going to understand that. In addition, 25 gauge has really, really made this safer as far as I'm concerned. And that's kind of a nuance that a lot of people just haven't recognized. Believe it or not all retina specialists in the United States even use 25 gauge. And to me, that's kind of a statement as to how varied your experiences with different doctors is going to be. So I don't want to say that I'm better, because I don't feel that I'm better than anybody. But I think that's why your experience, JD, is so difficult to explain. And I think in a word, it just comes down to, inexperience or unknowing. And I'm sorry that's your plight and it's so difficult, but everybody I see has been discounted for years or told to get used to this or they're crazy, et cetera, et cetera. And for all the people that don't really understand what you've been going through, it's really hard to explain why you got to go all the way to Fairfax. I get that. JB says, thank you, John. JB says, am I going to relocate? I don't know if I will. Just stay tuned. Nothing has been official. Tough question. MK, do you often see any tear in the retina during the surgery, and do you repair it? Does the repair cause loss of vision? Would gas help prevent a detachment? Would it be worth it to prevent this from happening, even if 1 to 2%? I see most tears during the operation. In fact, if you look at some of the videos, one of the things that I do at the end of the vitrectomy, right before I close, is I indent or depress from the outside of the eye to make sure I can see every bit of the retina. And I would say about 98% of tears are visible. 98% of the time I can find a tear. If I find a tear, I'm going to fix it right there. I'll usually use laser or I can use freezing. And that treatment, because the tears always happen in the front of the eye, you are never going to know it ever happened. It will not, it has no impact whatsoever on your vision. Dr. Wong, even with a PVD, don't you still have to remove vitreous off of the retina in other sections of the eye? If so, isn't that just as risky as a non-PVD vitrectomy? Can't there still be a tear in those sections where the vitreous is still attached? Not quite clear what you mean. My goal is to remove vitreous off the back half of the retina all the way out to the equator, and then as much as I can see anterior, realizing that it's impossible to separate the vitreous and the retina in the anterior or the front of the eye. You can easily do it in the posterior. You can't do it in the anterior part. I'm not so sure. I'm pretty sure I didn't answer your question, but I don't know what else to say. A different JB, if you do get infection in the eye, can it be treated successfully if caught in time? The answer is yes. As a retina specialist, I am tasked with treating endophthalmitis or infections inside the eye following cataract surgery. And there is definitely a correlation that the sooner you get to it, the better your results. From a liability issue, I just need to inform you that blinding infection can happen. The results are always in between. But a direct answer to your question is often with timely treatment, you can get pretty good results, but sometimes not. JD asks, do floaters tend to be non-existent in the anterior vitreous? So I'm going to tell you that in patients with PVD, the large opacities kind of collapse forward or move forward. In younger patients where I can't see the opacities, but I know they're there, I assume they're evenly dispersed front to back. Again, I want to highlight that I don't make it an issue to try and see what you're seeing. As long as they swish back and forth, I know that removing the vitreous is important. That brings up a question, well, what do I do about anterior vitreous and protection of the lens? I don't think that's an issue. I know others online think that's important. I just don't agree. JB asked, because in your videos, in one of your FOVs, you started the vitrectomy in a section where there was already a PVD, but then as you are cutting and sucking out the vitreous, aren't you separating the rest of the posterior vitreous from the retina? No, not necessarily. I'm just separating the vitreous that I can see during the operation, but the posterior hyaloid is probably still attached, but it's so far out, it doesn't matter. JT, what is the biggest difference between 23 gauge and 25 gauge? The biggest difference is the size of the hole or the size of the sclerotomy. The smaller the number, the bigger the hole. So the initial vitrectomy system was a 20 gauge. Then we moved to 23 and 25 gauge. There's also now 27 gauge on the market, and that's the smallest. The biggest difference, in my opinion, between 23 gauge and 25 gauge is that there's a greater chance of hypotony after surgery. And that may be why you read that certain surgeons put gas in every time. I never put gas in unless you've had a retinal detachment. And we're not having this webinar about retinal detachments. So it's not expected for me to put gas in. I think the biggest issue is the chance of having no pressure the next morning. I have tried 23 gauge. I don't like it. I've used 25 gauge almost exclusively for the last 5, 6, 7 years. I am waiting for 27 gauge to be delivered. However, it's not available. In case those of you are wondering, it's just not available for purchase yet. I've done it, and I will be doing some more this week, kind of as a favor to me by Allergan, Alcon, but it's not widely available yet. JT, my local retinal says 23 is better. Yeah, I don't know why he would say that. The only other difference that I can think of is that the instruments that you put in the eye, because the holes are bigger, can be thicker, so therefore they're a little bit more rigid. But once you're really adept with the 25 gauge system, I don't think there's any advantage at all to the 23 gauge. It could be an issue of tomato. JD says, does a pre-existing PVD reduce other risks besides retinal detachment? The only other risks would be endophthalmitis, and the answer to that is no, as far as I know. So the answer is no. I think that there is a correlation between the longer it takes to operate in anything. The longer it takes you to operate, the higher the chance of having complications. 25 gauge with a pre-existing PVD is a pretty quick, straightforward operation. So in that regard, it's kind of safer. Not so sure that it actually is safer in any other regard, however. So, JB, as I said before, remaining floaters after the operation can be from blood, inflammation from the surgery, or could be from Kenalog. And all of that should go away within a couple of weeks. Some people have said they still see some clear ones and black specks. Our perception of floaters and everybody's a little bit different. But I can just say in the usual sense or in the usual case, floaters after surgery are not from the floaters from the vitreous, because basically at the end of the operation, all the floaters in all your vitreous that you can see should be gone. MK. Do I think 27 gauge will further minimize retinal detachment? I don't know. I haven't done enough of them. In theory, that may be possible because a 27 gauge instrument will have a smaller hole in which to aspirate the vitreous, but it's really difficult. It's going to be very difficult to prove statistically that 25 versus 27 is better or worse. It's one of those events that if something doesn't happen very often, it's very difficult from a statistical point of view to prove something is better or worse. JT says, do I still do core vitrectomy only after discussion? I usually try not to. It's not an issue with older patients with a PVD. It can be with an issue with younger patients, and it's basically case by case. Do I have floaters? No. Would you get an FOV to remove them? Depends how much they bothered me. Our tolerance for floaters all varies. Our tolerance for blurry vision all varies. Our tolerance for pain all varies. I don't have floaters, so I can't really honestly answer that question. I know that if and when I need cataract surgery, because everyone's going to need cataract surgery if we live long enough, I'll have cataract surgery. I know statistically that the chances of complications are fewer or the same with vitrectomy. So you can probably read in between the lines. If they were bothering me, I'd certainly consider it. I think the question is who. Mark or John, I think we should wrap it up. It's been about an hour. How about just a last word or two from each of you? Mark, since I had John go first, do you want to say anything in closing?
No, your webinars are very insightful. I know that's what helped me take the next step to fly out and to at least have the initial consultation. So, I mean, once again, if you're sitting in the same position I was sitting in, you owe it to yourself to, one, visit the webinar, which you've done, and then two, maybe fly out and actually meet Randy in person and talk about your options. And I'm so thankful I did, and not a day goes by where I don't think about what a great move it was.
Well, I congratulate you in taking, that step, as I congratulate John also. John, do you have anything to say in closing?
No, I'm just very grateful. I'm glad that I had the opportunity, and I'm also fortunate that I live a little bit closer than other folks, but I would have made the trip having been there now. It's made a big difference, and I'm a big advocate. And as I told you, anything that I can do to help get the word out and let people know it's a good alternative, I'd recommend it.
Well, I want to thank everyone for coming. I want to specifically thank John and Mark for taking their time tonight to share their experience with the rest of you. For the other attendees who've been following us for a long time, at some point maybe I can meet you. I hope this is helpful. So the easiest way to keep in contact with us is to either follow us at www.retinaeyedoctor.com or www.vitrectomyforfloaters.com. If you need to get in touch with Chrissy, here's her email. It's rwongcm13@gmail.com. And I'd like to acknowledge Mark Erickson, who's provided us with these expert illustrations at www.jiradesign.com. Thank you, everyone, for joining. We'll see you soon.